Okay, so the next thing we're going to talk about is defects with decreased pulmonary blood flow. So just for a minute, pause the recording and think about what happens if we have a defect that makes more blood go into the regular circulation or the systemic circulation and less blood go to the lungs. So think for just a minute about what that's going to look like. Okay. There are two defects in this class. Tetralogy of Below is one of them, and it's actually a combination of defects. So we're going to look at Tetralogy of Below first. So let's look at what that looks like. So Tetralogy of Below is 4 defects that occur together. This child has a ventricular septal defect, okay, pulmonic stenosis, so from the right ventricle, this valve that goes to the pulmonary artery is tight, it's constricted. An overriding aorta, which means instead of coming from the left ventricle, the aorta is over this defect. So when blood goes from, instead of blood going just from the left ventricle into the aorta, it's over that hole in the wall, and so mixed blood from the left ventricle and right ventricle both go out through the aorta. And right ventricular hypertrophy, the right ventricle has worked too hard because of this pulmonic stenosis. It's worked too hard and it's gotten thick, so it's less effective when it's thick. So what happens with the blood? I want you to think for a minute about that combination of things. We have a valve to the lungs that's very tight. The valve to the pulmonary artery is very tight. Okay. We have an opening between the ventricles. So when this ventricle contracts, it tries to push blood through the pulmonary artery, but there's also this opening that's easier. So it's going to push blood through that opening and go into the aorta. Okay. So think about that for just a minute. Now, the hemodynamics actually vary depending on the size of that septal defect and how severe the resistance is in the pulmonary circulation and the systemic circulation. So if we have only a little bit of resistance here and this opening isn't very big, less blood goes this way, right? But if we have a big opening here, then any increase in pressure is going to mean a lot of blood is going to go this way instead of to the lungs. So if we have a big constriction here, a really tight constriction. So the severity of the ventricular defect and the severity of this stenosis really determine how much blood that should go to the body or should go to the lungs actually gets shunted back out and goes to the body. So part of the issue is we have deoxygenated blood going out to the body, but it's mixing with oxygenated blood. A bigger problem is that not much blood is going through the pulmonary arteries to get oxygenated. So that's what really causes the cyanosis. The shunt, usually this is a large enough defect that the pressure is equal in these ventricles. So even though we expect a lot of right to left shunt where blood can't get through here and so it moves over to the left side, they actually can shunt either way. They can have some left to right shunting and it can go back and forth, okay? The position of the aorta also determines how mixed that blood is. So if the aorta is more over the left ventricle and only a little bit over that defect, then it may get less blood. So really, there's a lot of factors that go into this. So cyanotic spells or TET spells are caused by an increased right to left shunt, okay? So what do you think happens when you have blood that not oxygenated needs to get to the lungs, okay? This valve is really tight, so it's hard to get through. We've got a really convenient opening here that goes straight to the aorta to send it out instead. So what do you think happens if this baby cries. That increases the pressure in the lungs, which is going to make even more blood or go this way. Okay, that's going to increase the right to left shunt, right? What do you think happens if this baby has some sort of vagal response and vasodilates? Or takes some kind of medicine, we give some kind of medicine that causes vasodilation. What do you think is going to happen? We've got less pressure here. So, and this is too much pressure. So we're going to have an increased shunt. So think about the kind of things that are going to cause an increase in that shunt. Remember, the shunt can go back and forth, but things that are going to cause it to go right to left and be increased. They need more oxygen. That's going to cause an increased right to left shunt. Okay. So at birth, they may be asymptomatic to cyanotic, but remember that pulmonic stenosis tends to be progressive. So as it gets worse, they tend to have to be more cyanotic. Okay. They'll probably have a systolic murmur. They'll have TET spells, which is when they have an acute episode of cyanosis and hypoxia. Now, you may see older kids with Tetralogy of Below who squat instinctively during that episode. How do you think squatting decreases the amount of blood that should be going to the lungs and is instead going to the body? How do you think that would work? Think about it for just a minute. Pause, and try to think through it. So if they squat, that increases the pressure on the left side of circulation because they're folding up those, their arteries, or they're increasing the pressure on the systemic circulation. Okay. They're folding at the hips and the knees, right? Increased pressure. So if we increase the pressure here, that evens it out a little bit and allows more blood to go into the pulmonary arteries. And that's kind of an instinctive thing that you will see kids with Tetralogy of Below do. These kids are at risk for emboli, okay? Because all of this here, the blood doesn't flow smoothly. It kind of swirls and swishes around and may sit still too much. So they're at risk for clots. They're at risk for seizures, for fainting, or for sudden death after a hypercyanotic spell. Well, all that makes sense, right? Because they're not getting blood flow to places it should be. Surgical management, the preference is to completely repair this. They want to completely repair this defect, have the aorta coming out of the ventricle, repair this defect, and open this valve up. And the preference is to do that in the first year of life. If they are not able to tolerate that primary repair right away, they actually can try to shunt some of the blood back over into the pulmonary circulation to improve pulmonary blood flow and O2 sats. Okay. This repair requires cardiopulmonary bypass. It is a major open heart surgery. The prognosis, operative mortality is 2 to 3% in the first 2 years after that surgery. Okay. You will also see, okay, remember, older kids who have this will sometimes squat down if they're having a TET spell because that increases the pressure here. So if you have a baby with Tetralogy of Below who starts crying and then suddenly turns blue, one of the things that you may see that nurse do is fold their legs up like they're in a squatting position, because that increases the pressure on the systemic circulation side, which will allow more blood flow to the lungs. Okay, we're going to move on and talk about tricuspid atresia, but I want you to pause and take just a few minutes to go back over Tetralogy of Below. How do you remember this is the one with 4 different things wrong? Tetra is 4, okay? So Tetralogy of Below is 4 different defects. Okay, next is tricuspid atresia. So let's look at it. Tricuspid atresia is when the tricuspid valve fails to develop. So blood can't go from the right atrium to the right ventricle. So we have blood coming back into the right atrium from the superior vena cava. Okay. It should be going to the right ventricle. If it can't go there, it keeps the foramen ovale open because they shunt over to the left side. So blood goes right atrium to left atrium to left ventricle to right ventricle, and then out to the lungs. So the blood flow that they're getting to go back to the lungs is through the atrial septal defect. If they usually have a ventricular septal defect. You notice that I said right ventricle to left ventricle. If they don't have that, they're going to get a lot less blood to, they really have to have that ventricular septal defect to be able to get blood to the lungs effectively. So they keep those fetal pathways open, but the blood's just kind of going in a circle and skipping this right atrium. Okay. It's also often associated with pulmonary stenosis and transposition of the great vessels, which we'll talk about in the next section, or yes, next section. So deoxygenated blood from the right atrium mixes with oxygenated blood in the left side of the heart. And then if they also have this pulmonary obstruction, that makes it even harder to get pulmonary blood flow. So what does this look like? Cyanosis, because they can't get blood to the lungs to get oxygen. They're probably tachycardic because they can't get blood to the lungs to get oxygen. They're short of breath because they can't get blood to the lungs to get oxygen. Older children are going to have signs of chronic hypoxemia. Non-surgical management. If they have a patent ductus arteriosus, they're going to do prostaglandin infusions to keep it open. They have to keep those alternate pathways open until surgery. The surgery is done in stages. The first stage actually is usually a shunt to increase blood flow to the lungs. Next stage, they do a bidirectional shunt. The third stage actually reroutes through the right atrium and pulmonary artery and bypasses the right ventricle. So they can't actually fix this to make normal blood flow, but they can fix it to be able to get some blood to the lungs to be oxygenated. Survival is about 90% at 50 months. So quite a few of these kids do survive, but they usually have multiple surgeries and multiple complications. Okay, we have one more section. I want you to go back and think about why these two defects are cause decreased pulmonary blood flow and what it's going to look like when your baby can't get blood to their lungs.